Hello and welcome. Thank you for joining. My name is Jessica Mulcahy and I'm a health educator for community health at Atlantic Health System. Today's program, Go Red for Women, is presented by Dicey McGrath. Before we begin, I have a few announcements. This webinar is being recorded and will be shared in its entirety on our website. All participants are muted. If you have a question, please use the Q&A button and use the chat feature for any comments. We will try to get through all of it at the end of the program. And here's a reminder to take care of your heart health. Atlantic Health System Heart Care provides award-winning, nationally recognized cardiovascular treatment services. We treat our patients and their loved ones with compassion and dignity as we navigate these complex medical conditions together. You can find out more about our heart care screening and treatment services by visiting atlantichealth.org/heartcareinfo or call us for a cardiac specialist at 1-800-247-9580. And with that, I'm going to turn it over to you, Dicey. Just give me a moment to share your presentation. All right. Can you see my screen, the screen, Dicey? Oh. Looks like you have control.
Jessica, you ready for me?
I'm ready for you.
Good. Good morning. What an amazing day. It's beautiful outside, and I am so incredibly grateful that on a morning when you could have chosen to do any number of things, you chose to spend some time learning about your heart and asking questions about it, and then giving us feedback on what your specific needs might be. Today, we're going to address women and heart disease. Not advancing, Jessica. Okay, there we go. Now, this has become a topic that is much in the public eye now. It was something that healthcare was a little behind the 8 ball on. In the early 50s, we began to study the phenomena of heart disease. And a physician named Caselli went to a little town in Massachusetts named Framingham and said, "Let me watch you." And they said, "Watch us do what?" And he said, "Live." They've monitored this town now for decades, and we have 4th generation in it. What we did, or what the study team did, was just monitor these people about every 3 or 4 months and monitor what they did, what their lifestyle was like, the choices they made, and what that meant to their health. And all of our risk factors for heart disease came from that. And we thought that women were just little men. So we would extrapolate that data to the population as a whole. And then we began to appreciate that women are not little men, that the phenomenon for us is very, very different. Jessica, I do not have control. This is your heart. This is what we're going to be talking about today. It's about the size of your fist. It is under your sternum. It points at your left foot. In particular, it's a muscle, much as any other muscle in your body. It has a purpose and a function. That purpose is to provide blood to your heart, have it return, go off to the lungs to be oxygenated, and then return back to the heart for being recycled through again. The things that we're particularly going to be interested in today are right here. These are your coronary arteries, and those are the origins of heart disease, which impacts in loss of function to you. The other thing that I want you to be aware of is right here. This is your aorta. That is going to come back to be an issue for us again. Now, when we're looking at disease relative to the aorta, one of the issues that we looked at in healthcare was, at what point does this disease begin? And we erroneously believed that this disease was only an issue for us once you were in your 20s. There was a survey done in the United States. This aorta has fairly advanced atherosclerotic cholesterol plaques in it, which in the coronary arteries, the origin of heart disease. This was the autopsy that parents requested on a child that had died in a motor vehicle accident. This aorta is 5 years old, and that is advanced disease. Hence, we began to rethink our whole issue of when do we begin to look at this disease. This is in the coronary artery. This whole disease that we're concerned with. This is that plaque formation and the alteration of that plaque. It ultimately yields heart attack or myocardial infarction. Bear in mind, this is your coronary artery, and this is where that plaque formation that you saw ties down. This plaque has pulled free from the wall that it was attached to, and now the cholesterol in the plaque has been exposed to the blood and the vascular system. This is a heart attack. And when you go to the cath lab, this is what we see. This is the clot that had formed. This is a heart attack. This is a myocardial infarction. This is what we're talking about today, disease in the myocardium. In the early 90s, in 1997 to be certain, the American Heart Association began to look at the phenomena of women and heart disease. We recognized in 1987 that it was a major issue, but now we wanted to quantify what women's experience was and what they knew and how we moved this whole program forward. The first survey was done in 1997. And in 1997, only 30% of 5,000 women who answered the survey knew that the greatest risk to their health was heart disease. In 2000, we repeated the survey and a modest increase to 34%. The education persisted, and in 2009, 54% of people who answered, women who answered that question, knew what the greatest risk to their health and their longevity was. So we had gone forward. Now, the other issue from this data is of those women answering, only 63% of those women said that the first thing they would do if they were having chest pain was call 911. So while awareness of heart disease had increased in the population, we were not able to make that specific to us. So of those 54% of the women who knew the right answer, only 13% of them considered heart disease a personal risk. Only 13% of them consider it a personal risk. This is the perceived response in terms of what the risk to you is. And this is the actual cause of death in the female population. In 1997, we founded a program called Take Wellness to Heart. It was indeed the first women's heart disease program that rolled out to the nation. In 2010, we changed that to Move into Action. And in 2003, we actually began to speak to women and said, when you want to make a powerful statement, what do you wear? And they said red. So February the 6th, 2004 was the first Go Red for Women Day. And we've had one, and it has been an ongoing thing every single year. We're on a Friday, everybody wears red. And on that day, we turn our attention inward. What is my personal risk? What is the personal risk of those around me? 1 in 3 women will develop heart disease. That's you or your mother, you or your daughter, you or your granddaughter, you or your sister, you or your best friend. Now, let's talk about the real impact of women and heart disease. In 1997, when we began to look at this disease, 500,000 women died every year. That is every single year from heart disease. With all of our work, we've made a pretty impressive reduction. We're down to about 422,000, which equates to 1 death per minute. In reality, a woman is 10 times more likely to die from heart disease from breast cancer. And in fact, coronary heart disease is the #1 killer of women above the age of 25. That's a conception that we've had difficulty getting out to the population. Women erroneously believe that heart disease is the disease of the older patient population, and that is not true. Heart disease claims more female deaths every year in the United States than the next 5 leading causes of death. More than 1 in 3 females has some form of cardiovascular disease, and 6 out of every 10 strokes are sustained by women.
There's a question.
Now, Jessica, are you going to do that?
Yep, I do have the poll. So I'm going to
Good.
launch a quick poll for you guys. So you'll see our poll that's come up, and it's just, has your healthcare team discussed your personal risk for heart disease? So we'll just give you guys a moment just to answer. And remember, there are no right or wrong answers here. Our goal is new knowledge today. All right. And I see that pretty much almost everyone has answered. Just giving it one more moment.
Good.
And thank you guys for participating. It's a early Friday morning, so it's always good to kind of shake things up and add some questions in to make sure everybody is awake. All right, so I'm going to pull the poll away. Thank you guys. We have a couple more polls, so look forward to some additional questions. And I'll turn it back over to you, Dicey.
Thank you. All right. Okay, now this is the data that we looked at. When we began to roll out the risk factors for heart disease, we began to impact on heart disease as a whole. But when we split it out into women and men, look what happened. In 1984, early 85, the death rate from heart disease split gender-based. Since 1985, every year, the risk for the death rate for women has exceeded men since 1985 in the United States. This is when, as a healthcare team, we began to look at this closely and recognize that the disease was very different, that women were not little men. And that's why we began to roll out the initiative to move heart disease forward, looking specifically at the female population. Now, earlier when I looked at the fact, when I spoke to you about the fact that the impact is decreasing, we are making a difference. Let me be more specific. You are making a difference. You are changing the face of this disease, participating with your healthcare team. But we noticed that there was one age group, women 35 to 54 years of age, that did not get a benefit. When everyone else saw a decrease in the mortality of heart disease across the lifespan, those women didn't. When we look closely at that population, we found that this population for women were overweight, and that 2 out of every 3 women greater than 20 years are overweight, or actually in the obese category. And that's why I believe that this group of women, this age span of women, in reality did not benefit from the reduction that occurred across the other lifespans. All right, Jessica, we're locked. Okay, now, let me also, the data that we're going to look at now, let me be specific. This is nationwide data, and I firmly believe that the data for New Jersey, and that's why we're asking you questions this morning, is better. I think that Jersey is one of the centers of excellence for heart disease, but still in the United States, in data retrieved from the American Heart Association and the American College of Cardiology, women and men are not treated equally when it comes to heart disease and our signs and symptoms. However, we are at greater risk. More women than men will die in the first year after a heart attack. More women than men will sustain a second heart attack within 6 years, and more women than men will go on to develop heart failure. Differences in treatment also exist, and this is one of the issues that the Atlantic Health System is very prominent in. Even today in the United States, women are less likely to get the drugs that we know are key to this care. We are less likely to receive beta blockers or aspirin. We are less likely to undergo invasive procedures, and we are less likely than men to be placed on lipid lowering drugs or antiplatelet drugs at the time of discharge. So even in the United States today, we are doing very, very well, but there is much more that we have to do. Your perspective is key. Your perspective is key. Women present differently than men. Our signs and symptoms are different. The degree, the discomfort that we have is different. And in reality, if we even have discomfort, is very, very different. So from the women's perspective, many times we attribute the symptoms to non-cardiac reasons. It's my stomach, I've got gastric reflux. We minimize the importance of the symptoms. I'm gonna walk this out. I'm gonna see if this just doesn't get better. I think if I just sleep on it, I've had a rough, strenuous day, it'll be better. And we put our role as a healthcare provider ahead of our role as a healthcare recipient. We put our roles and responsibilities ahead of our own medical attention, even now. So today, I would suggest to you that you cannot be a provider if you are not a recipient. You need to take care of yourself before you can meet the obligations around you. You can't pour from an empty cup, no matter what those obligations are.
We have the next poll.
Oh, perfect, perfect.
Another poll for you guys. And this time it's, if you thought you were experiencing signs of a heart attack, what is the first thing that you would do? All right. And I see some responses coming in. We almost have everyone. And again, thank you guys for participating. I think we'll just give it one more moment. All right. You guys are awesome this morning. So I am going to, oh, we got one more response in. All right. And with that, I'm going to pull this poll away and I will turn it back over to you, Dicey.
Thank you. I cannot advance, Jess. Nope, too far. Okay, now, coronary artery disease or coronary vascular disease is actually a continuum. We often look at it and say, I either have heart disease or I don't, but that's not really true. You have this huge continuum running from 0 to I have had a heart attack, and you are somewhere on that line. What we need to do, working with you, is determine a plan of care that's very specific with you. We need to match your plan of care to what your personal risk is. The heart attack symptoms in women are far more subtle than those experienced by men. In fact, I'm going to show you some data in a moment that says a lot of women don't have chest pain at all, even when they are sustaining a heart attack. We are not little men. We are not. That was a lesson that was hard learned by the United States. You can no longer afford to be the passive recipient of plans of care designed for you. You must actively participate with a healthcare team that you feel comfortable and competent about to develop a plan that is as unique and specific as every one of us. This is definitely not a one size fits all. In fact, we're looking at a one size fits one, and that's you.
I have the next poll. So we have our next poll. Get started. And that is, the next question is, women are less likely to experience chest pain than men, yes or no? Oh, you guys are fast today. Excellent. Wanted to get this one in before Dicey went over this. All right. Thank you guys for participating. And I'm going to turn it back over to you, Dicey. Thank you guys.
Heart attack symptoms in women. You may feel some of the same symptoms, including pain, shortness of breath, but those symptoms range in severity among women. And during a mild heart attack, women may be totally unaware that they're even experiencing an acute MI. Within my practice, I have had a significant number of women who thought other things, it's my stomach, I'm just tired, I've got the flu, different phenomena that placed them at risk of getting less than an optimum outcome because they were late in presenting to their healthcare team for assistance. What are our symptoms? They are different. Sometimes it's just stomach complaints. Now, men will come in and hold their chest and say, Dicey, I'm having chest pain. Women will come in and hold their lower abdomen and say, Dicey, I'm having chest pain. So in women, it can often mimic stomach complaints, or our sleep patterns are off. We are unusually tired or anxious. It is not unusual for a woman's heart attack to be linked to anxiety, sleep disturbances, palpitations, odd discomfort that may actually be between your shoulder blades. In Circulation, medical magazine, looking at the heart, 525 women. Now, what's unique about these women? They're all having heart attacks. More than 70% experienced no chest pain prior to having their heart attack, and 43% of them said they didn't have chest pain during the heart attack. What are your signals for action? What should you be concerned about? Any type of chest discomfort, squeezing, fullness, gastric distress, any uncomfortable pressure, particularly if that discomfort is exertional in origin. Now, women often have discomfort in other areas, such as our arms. And for us, between the shoulder blades is key. Neck, jaw, or again for us, stomach. Shortness of breath, breaking out in a cold sweat, feeling sick at our stomachs, or being lightheaded or dizzy. Additionally, we will experience weakness, fatigue, and some women who are experiencing heart disease symptoms will actually faint. Now, let's spend a moment talking about your risk. Risk is very individualized. First, smoking. Any degree of smoking places you at greater risk for heart disease. Family history. Have you had a close relative that has heart disease? And for women, it appears to be significant if that relative was a woman. Taking oral contraceptives, looking at your cholesterol numbers. Elevated LDL, that is what is routinely referred to as bad cholesterol. Low HDL, which is routinely referred to as the good cholesterol. And the third number is triglycerides. All fats are absorbed through the GI system into central circulation as a triglyceride. Diabetic, huge in women. It removes the grace period that women usually have over their male counterparts. Being perimenopausal or menopausal. Overweight. And the real issue for us is central core obesity. When you have weight that you gain between your ribs and your hip bones, that's a marker for heart disease. Hypertension, high blood pressure, having a sedentary lifestyle places us at risk as women. Now, you don't have to get extreme. One of the best things to do is just walk. Just walk. As we grow older, our age increases. And as we enter at menopause, our risk increases. And we have theoretically attributed this to loss of estrogen. The other issue that is very important in heart disease and to women is a phenomenon called metabolic syndrome. Metabolic syndrome in lay terms is often referred to as prediabetes. It is high blood pressure, abnormal cholesterol right here. LDL goes up, HDL goes down, triglycerides go up, and an elevated fasting blood sugar. That triad places you at risk for heart disease and probably places you at risk 10 years before you would actually enter a diabetic phenomena. And depression. Depression is very key in women, lots of literature. What are the three most significant for women? Elevated blood pressure, smoking, and elevated triglycerides. Very important.
All right, so we have another poll, and this one is about name the heart disease prevention strategy most significant for you. So we just talked about some of those modifiable and non-modifiable kind of risk factors. So what would be most significant to you? Improving diet, increasing exercise, stopping smoking, knowing your numbers such as your weight, your heart rate, your blood pressure, your blood glucose. All right. You guys are awesome. All right, I think we have everyone. Awesome. You guys are doing great this morning. Thank you so much for participating. I'm taking the poll away and I'm going to hand it back over to you, Dicey.
Now, and Jess, at the end of this, we're going to go over all these questions. Yes?
We can, yeah.
Perfect. Let's do that. All right. Now, the newest player are called emerging risk factors. And what are emerging risk factors? It means that the cardiac community is looking for risk that might increase the chances of heart disease that we do not consider mainstream. When I just went over are the risk factors that we know, but now we find then, that there are women having heart issues that don't have those risk factors. So now we're looking at things like, could it be your inability to process fatty acids? Is it a strange little part of your cholesterol called Lp(a) that places you at risk? Do you have a large inflammatory system moving? We know inflammation is part of this whole phenomena. C-reactive protein marks inflammation. And do you have an issue with clotting? So those are the new things that we're looking at in terms of heart disease. What can you do? What can you do? Get more information. I started working with women in heart disease in 1997 when we moved out, Take Wellness to Heart. I am an ambassador for the American Heart Association in their Go Red for Women because I believe in this. We can make a difference. No, let me be more specific. You can make a difference. You can own this and you can make a difference, but you cannot make a difference if you don't get more information. And if you have never had a healthcare provider speak to you about heart disease, then you need to initiate that discussion. What do you need to know? You need to know your personal risk. So as you saw in that early slide, we're coming a long way. We're making a difference. We're making a difference in the impact of this disease to women. So what can you do? Have regular checkups. Find a healthcare team that you are comfortable with, that you believe is competent, and most importantly, that listens to you and works with you to specifically address your personal risk. Know your numbers. Know your cholesterol numbers. Know your blood pressure. Know your blood sugar. Know your base heart rate. And have them help you to establish a program of regular exercise. The American Heart Association wants you to exercise 150 minutes a week. Walking counts. Absolutely, walking counts. Let me tell you something else that counts. Dancing with the vacuum cleaner counts. You know what I'm saying? Because I am not the only person who thinks vacuuming, well, I hope I'm not the only person who thinks that vacuuming is boring. And I'm out there dancing with the vacuum cleaner as I go through the house. You just move. Just get up and move any way you move, but make it something that you enjoy doing. Don't do what other people tell you you should do. Find a way of moving, and there's so many of them out there. Just move, just get up and move. The other thing that we looked at in women is, what do you think is a barrier to you in looking at your risk for heart disease? Why, what are barriers to you preventing heart disease and reducing your own risk? And these are the answers that we got back from the nation. Insurance or financial concerns. They actually don't know they are at risk, confident that they can change it on their own. They simply don't have time to take care of themselves. They have family obligations that get in the way of them addressing their own needs, language barriers in the healthcare system, and you just don't know what to do. And the other one that's coming to light recently is that the information being put out in the media is confusing. It's just confusing. So you just don't know, like the whole idea of butter, margarine, good, bad, what, So now, Jess, we have another question, yes?
Yes, we do.
All right, so we have our next question, which is asking you guys, what do you consider a barrier to your relative to your heart disease prevention? So insurance, finances, I'm too stressed to do things that need to be done, too much confusion in the media, and I just don't have time to take care of myself. There's a couple different options there. And I know, I'm sure some of you are saying, oh, I would like this to be multiple choice. Oh, it actually is multiple choice. Never mind, I did make it multiple choice.
It is multiple choice. And the last question is going to be, they're going to write in, but this is multiple.
Yep. All right. Looks like we have almost everyone. All right. I think pretty much everyone has answered, so and I will turn it back over to you. I'm going to end the poll.
Perfect. Just I need control back. Nope. Nope. Okay, good. Now, heart disease really doesn't care what you wear. We do Go Red for Women to make a statement and turn women's attention inward, but we are being stalked by a disease that has amazing capacity to reduce our impact in our roles and in our community, in our ambitions and in our adventures, and in who we want to be when we grow up. It really does not care what you wear. 1 in 3, and in the United States, 1 woman a minute. 1 woman a minute. Okay. Here's for you. All right. This is the Women's Go Red for Women. This is the website that's attached to the American Heart Association. You can go in one of 2 ways. You can call them and they will hook you up and you'll get lots and lots and lots of information sent to your home. Or you can go to AmericanHeart.org and sign up in the Go Red for Women. And then on your computer, you will get all the information and updates sent to you. Heart disease can be prevented. And now the data is out there that heart disease is the risk factor modification works better for women than men. We have that data now. So it works for us. We need to become active in preventing our health. When I was in my 20s, I lived in Chattanooga, Tennessee, surrounded by mountains. There was a mountain called Raccoon. The only way to get, there was this beautiful Glacier Lake. The only way to get to Glacier Lake was to hike in 4 miles and then rappel over the side of a cliff. The only way out is going to be to climb, but use that rope to pull yourself back up that cliff. When the work was a little rough, I would do that. I would hike into Raccoon Mountain, rappel over and sit by the Glacier Lake and feed the fish oatmeal cookies. I was up there one day and I heard activity behind me. Now, usually on Raccoon Mountain, that means you're about to be visited by a bear. And I grabbed my backpack and turned around and was getting ready to run. And there was a gentleman standing behind me. His name was Alex. Alex was 91 years old. Alex lived on Raccoon Mountain. And Alex had hiked in the same way I did. And he had rappelled over the side of that mountain. So I committed that I was going to do the things that I needed to do. So if Raccoon Mountain and that Glacier Lake had survived the time, on my 91st birthday, I was going back to Chattanooga, Tennessee and make that run, because Alex showed me that the things that we consider normal aging don't have to be. The decisions that you make today will be instrumental in opening or closing doors in your future. Opening or closing doors in my future. Every single one of you has an amazing gift to give, but you must gift yourself with health before you can gift the rest of the world with your contribution and your experiences. So now, Jess, our last one.
Yes, so our last poll, and it's not really a poll, it's an open-ended. So if you would like, when you answer this, please ignore that it says, please type your answer into the chat, because that's not actually an answer. What is a change that you will do to protect your heart? And we'd like to see what you personally think. And I believe that it should be anonymous, but either way, no one else will see. If you just direct it to us. But what is a change that you might do to protect your heart? And if you could type that into the chat, we would love to hear from all of you. All right, and I am seeing some responses. Thank you, guys. I do see trying to find a way to exercise enough.
Let's just give them some, we'll give them a little time here, Jess, to like put theirs in, and then we're going to take a look at the questions. Yeah, it's true.
Mm-hmm. Are you able to see the chat as well?
I can.
Excellent.
Awesome.
Yeah.
And Jess, you're going to give them the information so that if they want to find a cardiologist, or they want to get in touch with us with other questions or other needs in terms of speaking to the public, we can do that, right?
Of course. So after the
Awesome.
program, I can send out to everyone who has participated today, I can send out a copy not only of these slides, but also some information about some of our additional services and how to get connected into some specialists if that's what you need, or where to find some other resources. I'd be happy to do that. And Dicey, just let me know when you want me to take the poll away.
I'm sorry, Jess,
I said, let me know when you want me to take the poll away.
what do you think?
I know we've gotten quite a few answers already.
Okay.
And we
Now-
do have some questions in the Q&A as well.
All right, so I just click on the Q&A and they'll come up?
Yes.
All right.
I might have to take the poll away first.
Okay, question. How is the case of a 10-year-old demonstrating extreme atherosclerosis explained? It's usually explained by familial. It's usually genetic. Now, I can tell you where the best resource is around here. Columbia Presbyterian, after this data started to roll out, that showed us that we were behind the 8 ball on this in terms of when this disease actually begins to present itself. And we began to look at the pediatric population because we thought that this disease was, into 27, 28 is when we began to look at it. So yes, if there is a high familial issue, if there is aggressive dyslipidemia or abnormal cholesterol patterns that are familial, it can occur in the pediatric population, and they are looked at very, very closely. Excellent question. Oh, another one. Can you speak to women who were diagnosed with preeclampsia during pregnancy in connection with future heart disease, heart attack risk, and the likelihood for issues in future pregnancies? I cannot speak to the likelihood in future pregnancies, but I can speak to the fact that there is data coming out now that says what you very succinctly asked, preeclampsia and going on to have with the issues of heart disease is real. We are beginning to follow women who had preeclampsia very, very closely. That is an excellent, excellent question. And yes, we are seeing a link. How many of less typical symptoms of MI does a woman need to experience to call 911? If I ever called every time I had one of those symptoms on the list, I'd be calling almost weekly. Excellent question. Innately, women have known when something's different. There is something uniquely, in fact, many times when I was in practice, women would come to me and simply say, something's not right, Dice. I don't know what's wrong, but something's not wrong. I'm not myself. And that would bring them into their diagnostic modalities relative to heart disease. You know yourself. You know when this is different for you. Well, and let me tell you the other issue. When 1997 and we brought up Take Wellness to Heart, we learned, and even still now, that the national poll says that it was the low 80s, the number of women who, if they thought they were having chest pain and thought it might be their heart, would call 911 as their first issue. The same question asked about if somebody around you was having chest pain, would you call 911? That answer was in the 90s. So again, we just need to move yourself. And the other issue is you will, and you know what the other issue is? If you think something's wrong, move on it. And women innately know when something is different for them. After all these years, what are some of the critical conclusions of the Framingham study relative to heart disease in women? The new, excellent question. You guys are good. Oh my God, you guys are good. See, I have often thought that we didn't need to do lectures. We just need to answer questions. Now, the new data, in fact, we went back and looked at Framingham in 1987 when those death curves shifted and the death rate for women, mortality for men dropped and the mortality for women continued to escalate. That's when we went back to Framingham and started to tease out the difference. That's when we were acutely made aware of the fact that disease is different in women, the symptom is different in women, and the onset is different in women. So it is, the Framingham study is ongoing and we have now altered it. The other thing that did, and looking at the Framingham study, was more and more women are now in research modalities. We recognize that if we're going to look at heart disease and we're going to look at research, that when we look at differences in treatment, then we need to know that there is a female population in that group. Excellent. Oh, another good question. Is calcium score and echo for risk factor ratio already have high pressure, cholesterol, triglycerides, leaky valve, murmur, diabetes? Sounds wonky to me. That score be great. So I be great. Are all factors considered? Yes. Now, let's try another excellent score. Coronary calcium scoring and echoes are both used, and so is exercise stress testing, to look at the diagnostic modalities for the presence of heart disease, particularly in women. The echo is an ultrasound. The echo looks at the thickness of the heart walls. The echo looks at how snappy the heart is. And the echo looks at how the valves move. The exercise stress test attempts to quantify at an entry level what occurs to the blood flow to the muscle of the heart when you exert yourself. And coronary calcium score, here's the deal. As that plaque that we looked at that actually culminated in that heart attack, or you saw that ridging and blood portions on the wall of that coronary artery, as that heals, calcium is laid down. So when we do a coronary calcium score, we look at how much calcium is there in the coronary arteries, and we actually look at where is it. Is it in the left anterior? Is it in the face of the whole of the heart? Is it in the artery on the side of the heart? Is it in the artery on the back of the heart? And we extrapolate that to what is your risk for having active heart disease? What does this mean to you in the future? And those modalities are often used together, Excellent question. How do you recognize angina versus muscular? Excellent question as well. You guys are very, very good. Now, here's the issue. Anginal pain is usually exertional. You walk up the stairs, you get short of breath, and you get discomfort in your chest, your jaw, your back. You get discomfort. And when you stop what you're doing, the discomfort goes away. Muscular pain, although, and these are not carved in stone because there's always somebody out there that comes in with an atypical presentation. But muscular discomfort is usually point discomfort. Muscular discomfort is usually something that you can take your hand and push on it and you'll make it worse. Angina does not have point discomfort or point tenderness. If you're having anginal discomfort, it is usually related to exertion. And muscular discomfort can be related to movement. You can make it worse if you twist or turn, but many times when it's muscular, you can push on it, you can make it worse. Can I make this pain change in character if I push on it? If your answer to that is yes, it tends to lean itself more to muscular, because the issues are, you're absolutely correct. Chest pain can be a multitude of things. Inflammation in the costochondritis. It can be you have pulled a muscle. It can be you've injured a rib. It can be gastric reflux. It can be heart. So it can even be a pulmonary type of pain. Excellent. Why is AFib so common these days? Because we're living longer. Atrial fibrillation tends to end. Atrial fibrillation is generally a disease of the older patient population. You can see it in younger patient populations, but those are usually patients that have valvular dysfunction as well. And we are living longer and we are living better. So we are seeing an increase in atrial fibrillation only because our population is an older population, and atrial fibrillation generally presents itself in older age. Excellent, 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 excellent question. Is tingling your fingers a symptom of impending blockage? It can be a number of things. It can, in many populations, tingling in your fingers can be, the issue can be flow, vascular flow. If you have spasm, if your vessels tend to contract or spasm in response to heat or in response to cold, it can make your fingers tingle. If you are developing an issue like carpal tunnel, it can make your fingers tingle. But whenever you have numbness in any extremity for any reason, it always needs to be followed up. If you suddenly are having what appears to be vascular changes for any reason, always needs to be followed up. Excellent. What is the difference between heart rate and blood pressure, and how can you have elevated heart rate but not have high blood pressure? Another excellent question. What we track in order to perfuse to get blood from your heart and out to your fingertips and down to your feet is cardiac output. Cardiac output is how many times your heart beats a minute times how much blood you put out each time your heart beats. As your heart is strong, when it contracts, 50% of the blood that's in it gets out. As the workload on the heart goes up, the wall thickens as a response to something like high blood pressure, or the heart becomes weaker, that stroke volume drops. And to keep the flow going, your heart rate rises. Heart rates are also related to conditioning. If you work out and you exercise, you will strengthen your heart's a muscle. You can make it stronger. You can make it work better. And as it becomes more efficient, your heart rate will drop. Your blood pressure is a response to a number of things. The blood pressure is made up of two numbers. The upper number is called systolic. The bottom number is called the diastolic. The systolic number, or the upper number, is reflective of how hard that left ventricle, that lower left chamber that's going to pump blood to your brain, has to contract to get blood to the periphery. It's a working phenomena of that left ventricle. How much pressure did it have to exert to get the blood out? As that systolic pressure rises, the workload on the heart goes up. The bottom number is called the diastolic number. The diastolic pressure is the lowest pressure the vascular system is exposed to. As that number rises, again, the pressure that the vascular system is exposed to rises. High blood pressure occurs for a number of reasons. It can occur genetically. It tends to run in families. It tends to occur in certain phenomena. It tends to be correlated with diabetes. It tends to be correlated with kidney disease. There are issues that we look at, and as we grow older, those numbers rise. We used to think that that was not important. We know now that, again, we were wrong about that, and that it is. So the heart rate relates to how the performance of the heart and how conditioned the heart is. The blood pressure is an indication of the workload on the heart. As the pressure rises, the workload on the heart goes up. And if you have high blood pressure over a long period of time, that pressure can become destructive to your brain, the vascular flow to your legs, to the flow to your kidneys, to the flow to your eyes. But in reality, it is a marker of the work the heart is being subjected to, the pressure the heart is being subjected to. Excellent. Okay. When is fluttering heart a cause for concern? Anytime it changes. Palpitations you should always bring palpitations or fluttering to your healthcare provider's attention and then do the workup from there. Always, if your heart does not normally flutter and it starts to flutter, that needs to be brought to your healthcare provider's attention and needs to be addressed. Excellent question. Is plaque buildup and calcium buildup the same? Do women need to be tested for plaque buildup, and if so, when? As we grow older, we need to be. I can tell you now that the coronary calcium score is very, very popular, and many people are getting it done. In fact, it's on my radar. I don't have a risk for heart disease per se. My pressure is good. My cholesterol is good. I don't carry a risk factor in my family. I do extreme sports. So I climb mountains, I climb rocks, I climb ice, I whitewater raft, and I am still going to get a coronary calcium score just to have one more number that I know. I know my blood pressure is good. I know my heart rate is good. I know my glucose is good. I know my kidneys are good, but I myself am going to have a coronary calcium score. It's just one more way of knowing what, if anything, has occurred. And what is a normal coronary calcium score? 0. So yes, coronary calcium scores or calcium in the coronary arteries is a marker for heart disease in women, just as it is in men, and women need to be tested equally. What the issue for women is we get tested a little differently. Some of our testing modalities are different, but definitely need to be followed up. Can you experience discomfort in your calves before a heart attack? Now, not that I'm aware of, and not the literature has extrapolated out, but let me tell you this. Depends on how the discomfort in your calves is occurring. If you are having an ischemic phenomena, the plaque that forms in your heart forms in your legs and forms in your brain. The same phenomena, pathophysiologic phenomena that will ultimately produce a heart attack is at the foundation of a stroke and is at the foundation of peripheral vascular disease, which is disease in the arteries that supply blood to your legs. So if you are getting discomfort in your calves when you're walking, that could be a marker for vascular disease and would definitely need to be brought to the attention of your healthcare provider. If you are getting cramps in your legs at night, that's a different phenomenon, but still needs to be brought to your healthcare provider's attention. Cramping at night, leg cramps at night, not associated with heart disease, but cramping in your legs when you are walking that are exertional. You walk and your legs hurt, you stop and it goes away, you start walking again at the same point, like you walk a city, you can walk up a flight of stairs with no problem. You try and go up 2 flights of stairs, your legs hurt, your calves ache. When you stop walking, that discomfort goes away. Same thing. Another set of stairs, 1.5 flights, same thing. So yes, pain that is exertional in your legs is needs to be followed up on. Definitely needs to be followed up on. Ooh. Considering the difference in male-female symptoms relative to heart disease, are there any differences attached to the treatment, and should there be? We are just now beginning to look at that. We now know that women will respond to the same issues in cholesterol. Women will respond to drugs like beta blockers equally. So we are just now beginning to look at these treatment modalities in terms of how women, what in research modalities, how do we respond? Now, one of the issues out there that we've looked at very closely is the whole idea of aspirin may be different for women and men, And again, heralds a dialogue between you and your healthcare provider. This is also an excellent question. We are just now beginning to look at that, the responses of women to treatments that we have traditionally kept within the cardiac realm. Perfect. Can you discuss why someone might have PVCs I have always been told I have mitral valve prolapse, but now apparently I no longer meet the criteria, although I have all the neurological kinds of symptoms of the syndromes and PVCs, although my beta blocker blocks a fair amount of them. Excellent, excellent question. Premature ventricular contractions are often associated with mitral valve prolapse. It is the origin. Many women that have mitral valve prolapse present with atypical chest pain and palpitations or thumping in their chest that's more prevalent for them at night when they attempt to go to sleep. Very closely heralded. Mitral valve prolapse is noted on an echo. And as this individual has very appropriately pointed out, mitral valve prolapse is more prevalent in women than men. It is associated with premature ventricular contractions or extra beats or abnormal beats or early beats, all the same. And they quite often respond to beta blockade. And we're not really certain what the origin of it is, but we know that mitral valve prolapse, the phenomena of prolapsing, does indeed produce PVCs, which women experience as palpitation. They do respond to beta blockade. Can you reverse stiff heart syndrome? Depends on why you have stiff heart syndrome. If you have a stiff heart or left ventricular hypertrophy because of hypertension and you remove the hypertension, you can get some degree of improvement. If you have stiff heart syndrome because of an inflammatory process, that is a whole different phenomenon. If you have stiff heart syndrome because of a infiltrative process to the heart, all of those have different outcomes and different criteria. Excellent question. So the whole idea of stiff heart syndrome is the origin. What is the origin of that stiffness? Every single etiology has a different treatment modality, some of which you can improve. Excellent.
Hi, Dicey. I think
I'm sorry?
I was going to say, I think we're a little past time. So
Okay.
we could do one more question, and then there are a few more still left. Would it be possible for me to send you a list of the remaining questions? And then I could, if you have some answers for some of those, I could send them to.
Absolutely. We talked about aspirin. Excellent question. Aspirin is a real issue for women. But why is it different for women than men? Our side effect profile is bigger. I do have their side effect profile. The side effects that are occurring from aspirin are more specific than women are men. Oh, excellent questions.
Yeah, we've had a lot of really great questions.
Oh my God, these are awesome. You know what? If I did not answer your question, you will get one in the email. Jessica and I are going to meet, and you can expect that next week. And then you will have our email and you can get back to us. Now, one question that I should have addressed when we were talking about is HRT, hormone replacement therapy. What's the new answer? As we noted, the risk for heart disease in women increases after we develop menopause. We have about a 5 to 15, depending on the literature, or 6 grace period over men, where we develop disease much later than they do until we become menopausal, either surgically or naturally, and then our risk is equal. We thought that answer was very easy, that we would just put women on hormone replacement therapy, we'd give them back estrogen, and that would prevent that whole issue of heart disease. 2 huge studies came up. One was Women's Health Initiative, and one was HERS. The HERS 2 looked at women that had had a heart attack. We placed them on a specific HRT. It was Premphase. That's what they went on, Premphase. And we wanted to see in a research model if we could prevent a second heart attack in those women. Could we give them prevention by putting them on HRT? And the answer to that was no. And then the Women's Health Initiative looked at primary prevention, meaning people like me or Jessica that do not knowingly have heart disease, if we go on HRT at the point of menopause, can we prevent? Is it cardiac preventive? And the answer to that question was also no. So there are reasons to go on HRT, but if you are going on HRT to prevent coronary artery disease, either an escalation or an initial onset, the answer is no.
Excellent. So
Okay, Jess.
great questions from everyone. Thank you guys so much. And again, we will address these additional questions that we have not answered. I do apologize that we weren't able to get to all of them, but I am so happy that we were able to have Dicey today. And I think we'll conclude this webinar and you'll get a follow-up from us. Thank you for joining us, and a very special thank you to Dicey for dedicating her time and expertise today. If you have additional questions or comments, you can always send an email to communityhealth@atlantichealth.org, or you can give us a call at 1-844-472-8499. Have a great day, everyone. Thank you.
Oh.